Basics of electrocardiogram essential for PG entrance exam. For a proper understanding and to get to know about the fundamentals and grassroots basics about electrocardiogram, I recommend you to watch two of our previous videos based on the just fundamentals of electrocardiogram, how a lead is formed, what is an electrode, what is a lead, how potentials are recorded, what is a augmented lead, what is a normal lead, chest leads, what is a limb lead, bipolar, unipolar. Every basics has been covered in those two videos. I recommend strongly that you have a clear understanding of ECG by looking at those videos before you get on to this as such ECG essential for PG entrance exams, doctors. Now let us start with the first law, Einthoven's law. Okay, Einthoven's law states that the potential in lead 2 is nothing but summation of potential in lead 1 and lead 3. Right, the potential in lead 2 is nothing but the summation of potential in lead 1 and lead 3, doctors. We will move on to waves. P wave, we know P wave is due to atrial depolarization. Then ventricular depolarization is represented by QRS complex. QRS complex represents ventricular depolarization. Okay, so these two are waves of depolarization, doctors. The waves of depolarization are P wave as well as QRS complex, right? Now both these two waves represents depolarization waves. Moving on to the next waves, which are repolarization waves. Remember, both ST segment and T wave represents ventricular repolarization. ST segment and T wave represents ventricular repolarization. Okay. Now, why these two waves, both depolarization as well as repolarization are positive? That's absolutely curious, isn't it? Now let us get to know the fact here, doctors. While QRS complex, you take QRS complex first. The whole QRS complex represents ventricular depolarization, out of which Q wave alone represents septal depolarization. Q wave alone represents septal depolarization. Remember, Q wave is the very first negative wave. Q wave is very first negative wave in ECG. So the myth or the very old concept of saying all the depolarization waves are positive, only the negative depolarization wave is Q wave, it is not so, doctors, right? Do not get confused between the morphology of wave with depolarization or repolarization, right? T wave is a wave of repolarization which is upright. Remember, T wave is a wave of repolarization, but it is going to be upright. P wave is a wave of depolarization which is also upright, whereas Q wave is also a depolarization wave which is primarily downright, it is negative, isn't it? So the very first negative wave in ECG is Q wave. This is very important, very important. The first negative wave in ECG is Q wave, doctors, and it indicates septal depolarization, that is Q wave. Okay. Now R and S morphology. R and S, both these waves indicates ventricular depolarization as such. Both these waves indicates ventricular depolarization. Okay, what happens is, say for example, we have right ventricle and left ventricle, doctors. Left ventricle is quite thick, we know that, right? We just saw in the previous discussion also that we have a thick left ventricle. We also saw interventricular septum is both fibrous as well as muscular. Now let me consider the muscles of interventricular septum. As we saw, more amount of muscles are seen as the septum is coming towards apex of the heart, and it is also equally distributed with fibrocytes. Now, as I told you, doctors, the depolarization of septum happens from left side to right side. Depolarization of septum happens to happens from left ventricle, from the left side of septum to right side. You will be connecting chest leads, isn't it? V1, V2, V3, V4, V5 and V6, right? Always remember this one point you should be very familiar with. Of course, we have covered this in detail in the basics of ECG video. For a quicker understanding, let me give you the gist of the logic here. Okay. Now, if current travels towards active electrode, you will have positive deflection. At the same time, if current travels away from active electrode, there will be a negative deflection. So remember, if current travels towards active electrode, doctors, there will be positive deflection. If current travels away from active electrode, there will be negative deflection. Remember this one very important point, okay. So if you consider septal depolarization is happening from left side to right side, which means septal depolarization is happening towards V1 and towards V2. We just saw that if a current is traveling towards an active electrode, it will have an upstroke and it will not have a downstroke, isn't it? Since septum is getting depolarized towards V1 and V2, the leads V1 and V2 will not have Q waves. Lead V1 and V2 do not have Q wave, doctors. Please remember, Q wave is physiologically absent. in lead V1 and lead V2. So lead V1 and V2 do not have Q waves, and the reason is, what is Q wave? It is the very first negative wave in electrocardiogram. It is the very first negative wave in ECG. But if the depolarization is happening towards V1 and V2, it should be producing a positive deflection, right? Which is why V1 and V2 is physiologically absent. No, V1, V2 do not have Q waves. Now also get to know the second point. If current travels parallel to active electrode, ECG machine will write a flat line. This is also another important point to be kept in mind. So if there is a current travel parallel to active electrode, machine will write a flat line, right? Here if you consider V3 and V4, see the travel of septal depolarization happens more or less parallel to V3 and V4, isn't it? Just because current is traveling more or less in a parallel fashion to V3 and V4, Q waves may be present, may not be present in V3 and V4, right, doctors? Q wave can be present and Q wave can be absent. So presence and absence of Q wave is both normal in V3 and V4. That does not tells you anything significantly. Whereas if you consider V5 and V6, the orientation of active electrode is kept towards left ventricle and the current travels exactly in an opposite fashion to V5, V6. So there will be a definitive Q wave in lead V5 and V6. So you have a solid Q wave in V5, V6. So the question is this: the leads which shows consistent Q wave presence is, out of all these 6 chest leads, V5 and V6 are the definitive leads that shows Q wave, doctors. That is one very important point. Remember, Q wave indicates septal depolarization and it is the very first negative wave in ECG. Now coming to R and S waves, the same fashion, doctors. We have the same ventricle. Let us take up the very same diagram here. So to avoid confusion, let us take up same diagram. Okay, so we have the same lead structures, V1, V2, everything. Now we have the bundle branches. That flows on left side of interventricular septum, and then it divides into Purkinje fibers. Now remember, doctors, Purkinje fiber runs subendocardially. Now from there, from the subendocardial layers, it distributes fibers towards the epicardium. So, Purkinje fibers run subendocardially, point number 1 and very important point, and the wave of depolarization is happening towards epicardium. So, in this consideration, if you see in lead V1 and V2, right doctors, right ventricular depolarization is happening towards V1 and V2. Remember, right ventricular depolarization is happening towards V1 and V2, left ventricular depolarization is happening away from V1, V2. So, this is the direction of depolarization of left ventricle, isn't it? And it happens away from V1 and V2. So, in V1 and V2, the positive wave R wave and negative wave S wave, R wave and S wave. R wave indicates right ventricle, S wave indicates left ventricle in V1 and V2. Right doctors? V3 and V4. V3 and V4 are more or less isoelectric. There is no specification of ventricles in V3 and V4, right? You can't say R wave belongs to right ventricle or left ventricle, you just can't say, right? So, V3 and V4 usually used to be isoelectric, and you will have more or less a similar QRS morphology. R and S wave are more or less of same length. The length of R wave and length of S wave is more or less same, right, in V3 and V4. Coming to V5, V6 doctors. Coming to V5 and V6, if you consider V5 and V6 are located close to left ventricle. So, depolarization of left ventricle is happening towards V5, V6. Depolarization of right ventricle happens away from V5, V6. Naturally speaking, you have R wave and S wave, and R wave in V5, V6 indicates left ventricle, S wave indicates right ventricle, S wave indicates right ventricle in V5, V6. Now, if you consider midline doctors, right, R wave is very short in V1, V2, S wave is deep in V1, V2. Exactly opposite. When you come to V5, V6, R wave is very tall, S wave is very short, which means wherever there is left ventricular involvement, the waves will be very deep. The waves will be very deep or very tall. Such a good amplitude of left ventricular depolarization, right? This is the PG entrance question. Amplitude of left ventricular depolarization is greater than right ventricular depolarization. Amplitude of RV depolarization is more, amplitude of LV depolarization is more than RV depolarization, and the reason is thickened or increased presence of muscle mass. Where there is more muscle, there will be more current flow. Where there is more muscle, there will be more current flow. Since left ventricle is comparatively thicker than right ventricle, left ventricle takes up more current. That favors the lengthier left ventricular waves in ECG. So, the nutshell here is, doctors, if ECG shows S wave abnormality in V1, V2, R wave abnormality in V5, V6, this is a left ventricular pathology. If ECG shows R wave abnormality in V1, V2 and S wave abnormality in V5, V6, this is a right ventricular pathology. Remember, right ventricle is represented as R wave in V1, V2, S wave in V5, V6. Left ventricle is represented as S wave in V1, V2, R wave in V5, V6. These are all our waves of depolarization. Now, coming to ST segment and T waves, doctors. We finished QRS. Now, we will move on to ST segment and T wave together. As I told you, both ST segment and T wave, both are waves of ventricular repolarization. Now, if you connect the idea of a myocyte action potential with ECG, let me give you a diagram that looks somewhat like this, right? So, we have phase 0 of action potential, phase 1. Okay, doctor. So, let us take up the wave of repolarization in a different color. We have phase 1, phase 2, phase 3, phase 4 of repolarization, right. This is ventricular myocyte action potential. Correspondingly speaking, you have depolarization of ventricle represented by QRS complex, right, and repolarization of ventricle is represented by both ST segment and T waves. Okay. Now the beauty is we saw flat lines in myocyte action potential, that is formed by plateau phase, isn't it, doctors? Flat line in action potential is caused by isoelectricity. Cells electrical nature remains static. It is neither getting positive nor getting negative. If you could remember the discussion we had on the myocyte action potentials video, you could able to understand this, isn't it? So the flat line in action potential graph is due to isoelectricity, which is exactly replicated in ECG, doctors. The plateau phase is represented by ST segment and the T wave is represented by, the T wave represents phase 3 and phase 4 of action potentials. So if you consider the morphology of graphs, okay, the depolarization wave is correspondingly represented by QRS complex. Depolarization is correspondingly represented by QRS complex. First two phases of repolarization is represented by ST segment and the final phase of repolarization is represented by T waves. Final phase of repolarization is represented by T waves, doctors. Remember, both ST segment and T wave represents ventricular repolarization. Ventricular repolarization. This is ST segment and T wave. Right, guys? Now, I want you to be very familiar with the reason of T wave here, doctors. T wave. Why T wave is upright? Okay. So, let me take up left ventricle here for descriptive purpose. I have got a thick ventricle, doctors. Now, I have got Purkinje fibers that run subendocardially and fibers that are branching out towards epicardium, So, if you consider, I have epicardium at the out front, myocardium at the middle and endocardium at the interior, and the blood is filled in ventricular cavity. Here we have blood, doctors, and the one that is described in orange represents Purkinje fibers. So, if you could remember ventricular myocyte action potential, I was telling you that the duration of ventricular myocyte action potential is about around 250 milliseconds, right? It is not exactly. So, I told you different regions will have different electrical properties. Action potential duration differs. Okay, doctors. Now, if you consider the epicardial cells have got shortest action potential duration. Epicardial cells do have shortest action potential duration, while with a time duration of about 200 millisecond. While endocardial cells, the action potential duration of endocardial cells ranges to about 210 to 220 milliseconds. Whereas we have a cluster of cells in myocardial space, doctors. Myocardium has got a exclusively separate kind of cells called as mid-myocardial cell. These cells are called as mid-myocardial cells, abbreviated as M cells, which has got lengthiest action potential duration of about 250 millisecond. Okay, so we have active electrodes V5, V6 or any other active electrodes V1, V2, everything is kept close to the epicardial surface of ventricles, isn't it, doctors? Now, please be very clear here. Now, as the action potential of every single ventricle is happening till 200 millisecond, every ventricular myocytes will be in a state of depolarization, right? By the end of 200 millisecond, here comes the significant difference. By the end of 200 millisecond, the first cell to become absolutely neutral, is epicardial cell. By the end of 200 millisecond, epicardia become absolutely neutral. There is no current in it, right? It's been perfectly neutral, isn't it? It reaches its resting membrane potential. But if you consider mid-myocardial and endocardial cells, they will still be in action potential durations, isn't it? Because their action potential is either 210 milliseconds or 250 milliseconds, which means they have greater amount of positivity inside their cell compared with epicardia. So one side you have very less potential, resting membrane potential minus 90 millivolt. On the other side you have positive potential, somewhat minus 30 or minus 40, somewhat positive potentials. Current from endocardium and myocardium starts flowing towards epicardium. As current is flowing towards epicardium, doctors, you know very well, as current is traveling towards epicardium or towards any active electrode, you will have positive deflection in your ECG. In this case, as current is moving from endocardium and myocardium towards epicardium, in another way to be called as towards active electrode, you will have the first upstroke of T wave, doctors. So this forms the first upstroke of T wave. Okay, so this happens till about 210 millisecond. By the time endocardial cells also will go for, endocardial cell will also go for resting membrane potential. Endocardial cell will also go for resting membrane potential. It will reach negativity. But still, who holds positivity, doctors? It is our mid-myocardial cell, the superhero of ventricle, mid-myocardial cell, which has got a potential of about 250 millisecond. Now, endocardium is located away from active electrode, isn't it? Its active electrode is here, endocardium is present deep inside. Mid-myocardium is at the middle. So, current from mid-myocardial cell starts flowing backwards towards endocardium. As current is flowing backwards towards endocardium, you have active electrode in front and current is going backwards. So, naturally what happens, doctors? The deflection will be negative. So, the second half of T wave is due to traveling of current from mid-myocardial cell towards endocardial cells, doctor. This is how T wave is being formed. You have upstroke and downstroke. Now, for heaven's sake, please remember, if a current is traveling towards active electrode, ECG will write a positive deflection. If a current is going away from active electrode, ECG will record a downward deflection. For a detailed understanding, I recommend you guys to visit our basics of ECG videos so that you will have a solid and a smooth understanding of ECGs, right? So, the questions asked in T waves is, first question has been asked about mid-myocardial cells, the action potential duration of mid-myocardial cells. M cells are the cells with longest action potential duration. M cells are the cells with longest action potential duration, doctors, and the duration is about 250 milliseconds, right? Now remember, epicardial cells have got shortest, endocardial cells have got slightly in between action potential duration. This is how T wave is being formed. Okay, we just finished P wave, QRS complex as well as T wave. We just finished waves of ECG. We will take up segments and intervals. Always remember, segment represents flat line while interval represents a flat line plus a wave. Interval represents flat line plus wave, right, doctors? So, we will take up the very first segment or interval, that is PR interval. So, PR interval spans between onset of P wave till onset of Q wave or onset of R wave. Why are we not considering Q wave and we straight away goes to R wave? This is the reason. Q wave will be absent in 4 out of 6 chest leads. V1, V2, no Q wave, doctors. Physiologically, there is no Q wave in V1, V2. V3, V4, Q wave may be present, may not be present. Because of this inconsistency, we are not referring to PQ interval, we call this as PR interval, because R wave is a solid wave, R wave is the most definite wave, right? So, the duration of PR interval is about 200 millisecond. duration of PR interval represents 200 milliseconds. What does PR interval tells you? PR interval consists of P wave and PR segment, isn't it? So together this is PR interval. P wave, you guys know, this is atrial depolarization. P wave is atrial depolarization. PR segment. PR segment is due to AV nodal delay. PR segment is due to AV nodal delay. So AV nodal delay in ECG is represented by PR segment. Very important. It is represented by PR segment, doctors. Remember, the duration of PR interval is about 200 millisecond. Duration of PR interval is about 200 millisecond. Now coming to second interval, that is QT interval. QT interval tells you about onset of Q wave to end of T wave. QT interval spans from onset of Q wave to end of T wave. Okay, this means entire ventricular action potential. Entire ventricular action potential, doctors. Entire ventricular action potential from depolarization all the way to repolarization is represented by QT interval. Now the duration of QT interval is about 420 to 450 milliseconds. 420 to 450 milliseconds. QT interval is affected by heart rate, which is why we use a formula called as Besset's formula. Besset's formula to calculate corrected QT interval. To calculate corrected QT interval, which is abbreviated as QTC. C stands for corrections. Right, doctors? So QT interval represents the entire ventricular activity, doctors. Now how to calculate QT interval? So you got to pick lead with longest QT interval and you got to find a lead with shortest QT interval. Always the lead with longest QT interval should be taken as QT interval, doctors. Which lead out of 12 ECG leads, which lead shows the longest QT duration should be considered as QT interval. Now there is a phenomena called as QT dispersion. QT dispersion, which is nothing but the interval of QT segment in the longest lead as well as the shortest lead. Okay, lead with longest QT and lead with shortest QT. If the duration is about 100 milliseconds, it is normal. If the duration is more than 100 milliseconds, this heart is prone for ventricular tachycardia, especially torsatus D pointus, ventricular tachycardia and torsatus D pointus, doctors. This is QT interval. So to summarize these leads and interval, doctors, remember we have P wave whose duration is about 120 millisecond. PR interval duration is about 200 millisecond. Then we have QRS complex whose duration is about again 120 millisecond. It should be less than 120 millisecond. That is very important, doctors. It should be less than 120 millisecond. Then QT interval, we just saw that, which has got about 450 millisecond. T wave as such, which has got about 160 millisecond in duration. These durations are of extreme importance. Any kind of drug toxicity or electrophysiological abnormalities can be seen or manifested with either prolongation or shortening of these durations, doctors, depending on the kind of pathology the heart is suffering from. So these are all the normal ECG waves, segments and their duration, doctors, right. So let us move on to discuss about the axis and vectors in ECG in the next video.